Hello, everybody, and welcome to yet another episode of Fridays with Dhawale. I am Dr. Swapna Kamath, MLD MHI Alumni 2005. I'm currently practicing as a homeopathic consultant and a psychiatrist in Mumbai. And today we are going to discuss the challenges in homeopathic treatment of autism. So we are going to take this via a case, and then we will be discussing various facets about autism as well as homeopathy. So looking ahead, what are the objectives of our presentation? So understanding the challenges in the homeopathic management of autism. Our next objective is perceiving the clinical picture of autism via the case. Learning the tools required to arrive at a diagnosis. The next is understanding the benefits of an interdisciplinary team in the management in the cases of autism. Next is understanding the biopsychosocial model. That is how and why it is important to understand the genesis and diathesis in the evolution of a disease. And last, understanding the scope of homeopathic intervention in autism spectrum disorders. So, taking these objectives, let's go ahead. The case is about a 4-year-old Master Advik. He was studying in a mainstream school, and this child was referred to me by the class teacher in the resource room where we work with the kids in the counseling department. So the reason for referral is that in one of the workshops that I had conducted for the teachers, I had told them that you all generally refer students who are very hyperactive, who are very mischievous, who are very restless. But at the same time, it is important for the teachers to understand that a child who is very quiet and sitting in one place and not behaving like the children of his age is also a reason for concern. So this was what that the teacher had really inculcated. And when she came to the resource room, she told me that, ma'am, I remember what you had told, and I want you to come and see this child. He doesn't behave like any other 4-year-old children. He's very quiet. He does not smile. He does not mix. He does not take pleasure in any of the activities. And he needs assistance for every single thing. Like, he doesn't even go and open his bottle to drink water. He has to be fed. He does not go and keep his book in the cupboard. So he needs assistance for every single instruction. So with this feedback, I decided to go and do the classroom observations, and the summary of the history from the parent as well as the teacher and the classroom observations is as follows. The child was hyperactive, he was restless, he would not sit in a place for a given period of time. The sitting tolerance was around 5 to 10 minutes. The response to the name was there. However, his eye contact was fleeting. He would not maintain his eye contact for a longer duration of time. His gross motor and the fine motor skills were underdeveloped. So he could not jump, he could not hop, he was very cautious. He had an underdeveloped tripod grip, so he could not hold a crayon and he could not scribble or write. There were sensory concerns. He was very tactile defensive, according to the mother. He would avoid taking a bath, brushing, cutting nails, playing in the sand, in the mud. Advik was very good at the comprehension level. So he had very good concepts and he could grasp a lot of details. So if you would ask him any color or any object to identify, he could do all that. However, at the language, there was no reciprocity. So there was echolalia. So if you just ask him, how are you? He would reply back saying, how are you? So there was reciprocity difficulty, and there was echolalia mostly presented on reels, that is receptive on expressive language scale. We saw that his language development of receptive scale was around 27 to 30 months, and at the expressive scale, it was around 20 to 22 months. At a social emotional level, Advik would not express his anger, he would not smile back, he would not take pleasure in any of the social activities. He avoided crowds because he did not like to go in crowded places. Playway was there, he would engage in play with his classmates, but however, he would not establish friendship. Because of the language difficulty, there was no conversations. His self-help skills were majorly affected. He was unable to eat on his own. He needed assistance for all the activities of daily living. The birth history revealed that it was a full-term baby, C-section. She was an elderly primate. The birth weight was normal. The child had cried after birth, but the mother had developed gestational diabetes in the second trimester. Milestones, both the motor and speech milestones were delayed. Advik had started walking around 1.6 years and babbling was around 18 months. The parents were called, the parents were counseled, and they were asked to go for testing so that they could understand that the child had some difficulty. So not that the parents were not aware that the child was having difficulty, but however they thought it was more of a personality, and that's why he would not speak to others, and that's why he was not mixing. The test results revealed that his hearing, that is Bera, was normal. On the Vigilant Social Maturity Scale, it was 105. It suggested average social functioning. On the DSM criteria, he met the criteria for autism spectrum disorder. On Gilliam Autism Rating Scale, it suggested that there was a likely probability for autism spectrum disorder. And on Corner's rating scale, his scores were high for social functioning and atypical behavior. The recommendations that were given to the child was that he would benefit from a sensory integration therapy, occupational therapy, and a social skill training or a group therapy. Subsequently, remediation should follow in the resource room. So this is the entire gist of the case. Now let's go ahead to understand how did we arrive at the clinical diagnosis, or what is the presentation for autism. So as we all know, autism is a neurodevelopmental disorder and it affects three major areas. That is your social communication skills, your language development. There are behavioral issues, that is there are stereotypical patterns, ritualistic patterns, and there is affection at the cognitive level. So if you see at the left side, we have a pyramid of learning, and there are different stages of development which takes place, which are necessary to be developed in order for a child to learn or function. In autism spectrum disorders, we normally have a dysfunction at the level of sensory function. So your auditory, your visual, your tactile, your vestibular proprioception systems are either hyper-stimulated or hypo. So there can be a dysfunction at the level of a sensory system. Once your sensory system is affected, what affects later is the sensory motor development. That is the gross motor skills, the fine motor skills, the planning, the awareness of the body with respect to the environment, your body schemes, your reflexes, your ability to screen input and to produce an output is then affected. The next level of affection is seen at the perceptual skills. That is your auditory perception, your visual perception, your eye-hand coordination, your spatial skills are affected, thereby your auditory functioning, your language skills get affected. And finally, if you see the peak of the pyramid, there is affection at the level of cognition, that can be the academic difficulty. There is affection at the level of activities of daily living. And what you then get is the behavior that is affected. That is your ritualistic or your stereotypical patterns or your hyperactivity and aggression is then at the peak of the trial. So let's try to correlate this with Advik. Advik had sensory issues. Yes, there was tactile defensiveness. He had difficulty in hair cutting, brushing, cutting his nails. There was also difficulty at the level of tactile and auditory. He would avoid going out. He would avoid crowded places. Both his gross motor and the fine motors were affected. He was cautious. He would not jump. He could not hold a crayon. So his tripod grip was affected. At the language level, there was echolalia. At the social awareness level, emotional level, he had difficulty to relate. So he could not relate his emotions. So even if there was a playway, there was no communication. His eye contact was fleeting. He would not maintain his eye contact for a long time. Then the behavior, that is the hyperactiveness, the restlessness. He had a poor sitting tolerance for around 5 to 10 minutes. And then what do we see in the end? Yes, the activities of daily living. He's, removing the bottle, taking out the bag, everything was affected. He would not take out his belongings and keep them in the place. The parent also gave the history that he could not brush, he could not hold a thing. And then at the level of cognition, yes, Advik was a bright child. He was intelligent and he would remember minute details. So if we understand autism as a spectrum disorder, we have children who are normally affected from one end of the spectrum to another end of the spectrum. So there can be a hypersensitivity as well as at the other end of the spectrum, the child could be a hypersensitive child. So this is why autism is also called as autism spectrum disorders, At one end, we could have a child having a very good cognition. At the other end, there could be a child having severe intellectual disabilities. Having understood this, let us go ahead. Then what are the diagnostic tools that are required to reach to a diagnosis? So the diagnostic evaluation criteria for children with autism spectrum is normally based on your observation, your clinical judgment, and the information that we collect from the parents or the caregivers. So we have a team of a psychiatrist or a developmental pediatrician, a psychologist, an occupational therapist, a speech therapist, a special educator. So it's a part of an interdisciplinary team that normally work in accord with each other and help to understand and reach to a clinical diagnosis. Yes, they collect relevant history, information, your behavioral history, your child's developmental history, your medical status, a proper physical evaluation, a neurodevelopmental evaluation is taken up, your vision and hearing tests are conducted, and then we have certain rating scales or tools we can say, which are employed to find out whether the child is having a spectrum or not, or whether the child is on the spectrum or not. So the scales commonly used are like the childhood autism rating scales, Indian scale for screening autism, we have the MCHAT scales, and we also use a social maturity scale, which helps us to understand at what level is a developmental gap between the age of the child and what is the functioning of the child. So that is the Vinland social maturity scale. So these are in short diagnostic tools that help us to arrive at a diagnosis. Going ahead, what is our role as a homeopath in the management of autism? So as I said, autism is a teamwork, and it says that it takes a village to raise a child. So yes, we require an interdisciplinary functioning or a team to understand, to evaluate and work with the child. What is our role? If you see this slide, that there is an imbalance between the development and at the other end, at the level of functioning, at the level of communication, at the level of language. And our medicines, when given, they work at the level of susceptibility, this altered state of susceptibility and sensitivity, and helps to bring about a coordination between the development and the function. So this is exactly where our medicines act. It helps to strike a coordination and thereby building a balance between the development and the functioning. How? I will take you ahead. So finally, what is an interdisciplinary team? If you see the various facets which we have put together, in the case of autism spectrum, that you need a role, there is a role of every person who plays in, in identification, in working, in therapeutic development of the child. So we have a team for occupational therapists, speech therapists, we have the homeopathic psychiatrist, we have ENT specialist, ophthalmologist, a developmental pediatrician or a psychiatrist, a psychologist, and a special educator. When this entire team comes together, we can definitely see a lot of progress in the functioning of the child. So let's go ahead with the case. The parents were called for evaluation. The parents did the evaluation, and they were very much willing to start with the therapies, as well as they insisted that we start homeopathy for the child. So on that, I took the history from the parents and got to know that Advik was a quite shy child. He wouldn't interact much. He was very sensitive. He couldn't be spoken with a harsh tone, and if it was told to him in a certain manner, he would stop working. So everything had to be put up to him in a very nice tone so that he could work, and he could not be pointed out at certain mistakes. It had to be corrected in a very right fashion. Then only Advik would respond properly. The mother said that there were no temper tantrums. He was a very good boy, but he would not communicate. He would not express. His physical judgments revealed that he had a tendency to past history. There was a past history that there was a tendency to catch cold easily, and he had recurrent cold and cough. His appetite was generally low. He was a fussy eater. He had to be fed. Thirst was normal. Advik had cravings for ice creams and cold drinks, but they did not give him because he would catch cold easily. There was no specific aversions. Advik had perspiration in the palms, and the mother also said that whenever he would wake up from sleep, his entire pillow would be wet. So there was perspiration at the nape of the neck while asleep. He had frightful dreams, so he would wake up almost every night with frightful dreams, and he was a chilly patient. So I was very happy and confident, I think, after receiving this entire case. I thought I had hit the bull's eye, you know. So in two ways. One, that the diagnosis was arrived in a very, very nice manner, so that, you know, early intervention would be something which is very useful in autism. And the second important thing was that I had a silica drug picture right in front of my eyes. So this, without any hesitation or without any moment of thought, I immediately prescribed Silica 200, understanding the susceptibility and the sensitivity. We went around, I went ahead with the moderate dose and moderate potency, and we selected Silica 200. This dose was repeated initially once in 15 days and then weekly. Along with this, the child was put on sensory integration therapy. He was with the occupational therapist who was working on the motor skills. And in the resource room also, I would observe the child. We would work with remediation and give him a lot of activities for his motor movements. My observation into 3 months of treatment, that is both medicines and therapy, his hyperactivity and restlessness definitely had reduced. The sitting tolerance had improved. It was around 15, 20, 25 minutes. The self-help skills was improving. His fine motor skills, the grip, the pinch was improving. The gross motor skills, Advik had now started jumping from a feet of, half a feet. His eye contact was there, but still he would maintain it only for a few seconds. My concern was still there. I was not very happy. Why? Because the sensory concerns remained as they were. So his tactile issues, his going in the crowd was still just the same. There was still echolalia. The dreams were unaffected. He would still have nightmares, and the cautious behavior was now increasing. It was almost that he would hesitate to do any new activity. So this was another thing. So I understood that there was a partial response to the case, and whatever I had got from the case was not truly the entire picture. So I reviewed the case again, and I didn't find any major data that was really missing in the case. Thereby, I decided to again ask details about the maternal pregnancy history, and then the details were taken. What I then got in the history was that the case was that she was a working lady, late marriage, late conception. She was not ready for pregnancy. She used to be very angry during pregnancy at her husband because she had to manage both her house as well as her work. So there was a lot of burden at work, and when she would get back home, there was no support from her husband. She said she felt lonely at times. She used to be scared, especially in the night, and she thought that she would lose her son due to the overwork. She had frightful dreams almost every night, and that's why she would sleep with the lights on. I wish I could run away from this. This is what she really said. This was her statement. And then she developed gestational diabetes in the second trimester. From here, I reformulated the totality and came to the following: that there was aggravation dark, there was aggravation solitude, there was desire for light, she had an escaped desire, and dreams were frightful. The remedy selected thereafter was stramonium, and I gave him stramonium single dose, and then the child was observed. What changes were seen thereafter was really substantial. His eye contact started improving, his echolalia was reduced, his self-expressions had improved to such a great extent that now Advik would get angry and he would express his feelings. The episodes of dreams had considerably reduced. The mother also gave a feedback that Advik had started sleeping sound. His hyperactivity, his restlessness reduced. Sitting tolerance had further improved. Most of the tactile concerns had improved. A few vestibular proprioceptive difficulties had started coming up. There was, eye-hand coordination difficulties. There was difficulty in balance because of the low tone which was already there. So he had a few issues which were still going. Subsequently, I kept him on stramonium in frequent doses, and along with sensory integration and the remedial education in the school. 1 year of working with the case with both homeopathy as well as with therapeutic interventions, we re-evaluated the child, and what we found was that he did not meet the criteria for autism spectrum disorder. More or less now what was there in the reports was just a little bit of sensory concerns which he was having, and he was just presented as a case or a child of sensory processing dysfunction. Coming to what is the importance or the benefits of these ancillary measures which we use in autism spectrum disorders. So as I mentioned that Advik was kept on sensory integration and occupational therapy, let us try and understand how each therapy plays an important role in the development of children on the spectrum. So when a child normally has, when we saw the pyramid of learning, our primary affection is for a sensory dysfunction. So what do we need to correct it? We would need sensory integration therapy. That would work on the child's auditory, the visual, the tactile, the balance coordination, the proprioception, the oromotor or the gustatory skills that would help to bring about an integration or a balance for the dysfunction which is at the sensory level. We know that there are these 5 senses which are very important for learning, and any imbalance seen at the sensory level would further affect the pyramid of learning. The next, the occupational therapist works on the hyperactivity, the sitting tolerance, the attention span, the gross motor and the fine motor skills, thereby improving the cognition and then the play weight. The speech therapist usually works on the oromotor skills, helps the child to develop reciprocity, language development, helps in conceptual understanding. The special educator, on the other hand, works with the reading skills, the writing skills, the mathematical abilities. We teach the kids functional academics. So the overall improvement in the comprehension and the cognitive level is then seen to. Along with this, older children on the spectrum are also worked with their behavior issues. We called it as applied behavioral analysis, that is modification of the behavioral issues. A lot of means such as picture exchange communication system or the PECs are used to control the anger or the stereotypical patterns and the fixations. Dietary modifications are very, very important. So if there is a lot of restlessness or a hyperactivity, the child is, the parents are asked them to put on a very specific diet. So we avoid a lot of junk, aerated drinks, colas, chips and chocolates. And along with that, they are also seen to be put on a GFCF, that is a gluten-free, casein-free diet or a keto diet. These are all trial and error systems. So yes, it may definitely benefit a child, or it may take a little longer time, but yes, they definitely show improvement. Older kids on the spectrum are also worked upon with their pre-vocational skills and their vocational training to try to develop what is their area of interest and what is the occupation in which the child can be worked upon. So trying to understand why and how these ancillary measures are very important, let us go ahead with understanding what is the role of a biopsychosocial model in the genesis of autism. So we know that there are many predisposing factors which predispose an individual towards the disease. So there is a biological factor, a psychological factor, and an environment or a social factor. Normally in autism, you have the genetic factors, the mutations, maternal diabetes, thyroid. At the environmental level, there is exposure of the fetus to toxins or sodium valproate, a preterm baby, older parents. Psychologically, there would be stressors which are there, maternal stressors. What is there in our case? Yes, the mother had gestational diabetes. At the environmental level, there was a late marriage, late conception, there was job stress, poor financial support. At the psychological level, she had a lot of anger, loneliness, there was fear. So all these things, when put together, they predispose an individual, or they are setting a ground towards the development of a disease or building up a diathesis towards a disease. Going ahead, let me take you to what is my understanding of the case. I would like to differentiate in 2 spectrums. One is the clinical understanding and one according to our Hanumanian principles. So clinical understanding would be the importance of early detection, identification and intervention definitely leads to improved prognosis. Advik was identified when he was 4, and within 1 year of proper treatment and therapeutic intervention, we saw that a child would no longer be on the spectrum. He was just showing a few sensory difficulties. So that is one of the most important learning that we take back, that when a child comes at the age of 8, 9, and he's detected at that age, a lot of parameters in your development A lot of parameters in learning have already taken place. To reverse these cases, you always take a longer time. As compared to early detection, identification, you see very good results, and definitely the prognosis is very good. The importance of biopsychosocial model in the genesis, manifestation, and the outcome of the case. So when you enter the case, when you understand the case from this facet, it is very essential or beautifully brought about that what it can lead to. It can help you to conclude on certain facets which you are missing in the case, and it definitely helped me in my understanding. I had missed a very important part in the case. Now coming to Hanumanian Principles, yes, the art of case taking, as mentioned by Dr. Hanuman, and freedom from prejudice, which is given in aphorism 6. So as Dr. Hanuman mentions that a homeopathic physician needs to be an unprejudiced observer, and we don't need to jump into conclusions, maybe because of our past influences or our past experiences. Treat every case individually and treat every case as if it is totally different. So this was my learning from the case. I was definitely very prejudiced. I saw a silica duck picture, and without hesitation or without even entering into the history or the genesis, I prescribed silica just to see a partial result. Again, importance of the predisposing factors or the diatheses. What is a diathesis? It is a combination of attributes and temperaments which predispose an individual towards the disease. So this is also very important because understanding the diatheses, we come to know what can predispose an individual to the disease. And finally, my learning from the case was that a remedy which is selected on correct principle, it alters the susceptibility, strengthens the constitution of the individual. So finally, I take you to what is the scope of homeopathic intervention. Yes, our remedies work wonderfully. They help you in this entire pyramid as I had shown earlier. There is improvement at the level of the senses. There is improvement at the level of perception. Our medicines act wonderfully at the level of behavior to control the impulsivity, the aggression, the stereotypical patterns. It promotes cognitive development and the language development. It normalizes the physiology, any alteration in the sleep, the bowels, the bedwetting. It boosts the immune system of the child, thereby reducing the further risk to infections. And yes, it also minimizes these side effects which are caused by antipsychotics or antiepileptics. So homeopathy acts wonderfully on all these areas and all these facets. And as mentioned earlier, a tricordial team or an interdisciplinary team along with the homeopath can do wonders in treating cases on autism. So this is my entire learning from this case, and this is my entire idea to present this to you, that how we as homeopaths can really create miracles for children on the spectrum. So taking ahead, thank you so much for a patient listening. I would definitely like to thank everybody at MLD-MHI for not only giving this platform, but my teachers, Kumar sir, Department of Psychiatry, for their continuous guidance and giving us the, the vision, the determination to do to what we are today. The therapists who I've been working with, their continuous inputs help me to upgrade my knowledge about autism. And yes, the children on the spectrum, whom I feel I'm indebted to all my life because they teach me something every single day. So a big thank you to all of you, and thank you for your patient listening.